Good morning. Good morning, everyone. So we're gonna start second day live demonstration session. So with a complex TAVR, and I'm happy to have Alan Yeung as a co-moderator. And so I'd like to panel Dr. Chandra, Dr. Choi, Dr. Hachinohe, Dr. Han Jung-Kyu, Dr. Hong, Dr. Kang, Dr. Duk-Woo, and Dr. Yamamoto. Come on under. Yeah, stage please. Thank you. So, there you go. Okay, good to see you. Yamamoto, please.
Okay, great. We're going to go over to Asan Medical Center then, both case 8 and case 9.
Good morning, Alan, and good morning, everyone, and welcome to the second day first live case. And this session is a complex TAVR session. We will present diverse complex TAVR scenario. I'm DW Pa. I'm going to introduce our team and Dr. Su-Hyuck Ahn and Dr. Kyung, so our third grade fellow. Okay, we're gonna present the patient background, and Dr. Seo, can you present patient history?
Yes, thank you for your introduction, Professor Park. I'm Kyung Seo in Asan Medical Center. I will introduce this case. 80 years old male was admitted for dyspnea, and he has a past medical history of CVA, and his BMI was 24, and STS score is calculated 4.6%. Baseline electrocardiogram shows sinus rhythm, but now EKG monitoring shows atrial fibrillation, and chest PA shows no significant lesion. Echocardiography shows normal LVEF, and AVA was 0.77. Opening limitation of aortic valve and mild AR, and septal hypertrophy was observed. Aortic valve area was 0.77, and LV ejection fraction was 69%, and aortic valve pressure gradient mean value was 53, and trans-aortic valve peak velocity was 4.7. On CT findings, annulus area was 517, and SOV area was 1,135, and STJ was 608. LVOT area was 469. Coronary height of LCA was 14.7, and RCA was 23.7. Calcium volume of aortic valve was totally 805, and mainly in LCC. Heavy calcification in peripheral arteries, and minimal diameter of peripheral artery was 5 to 6 millimeter. This is the sizing table for SAPIEN 3 and aortic valve. So we planned the TAVR procedure using pre-dilation with 20 millimeter GMAT balloon and SAPIEN 3 Ultra 26 millimeter 2cc filling provides 9% of sizing.
Okay, can can you see the echo slide? Yeah. Okay. So, and the previous one. Okay, play. So, and if I'm gonna summarize this patient is 80-year-old male and presented DOE, functional class 2 and 3. And looking at the echocardiography is combining very severe AS in the lateral wall and septal wall, and more than, I think, approximately 2 centimeter. And initial, the BMP was elevated, anti-pro-BMP elevated 554, and by definition, these patients combining severe AS and LVH elevated BMP, and is a heart failure preserved ejection fraction. So, and among the patient undergoing the TAVR procedure, such like heart PEP and the preserved ejection fraction is very common. Is I think more than 60-70%, and so usually after successful TAVR procedure, interventional cardiologists don't care about the post-TAVR medication. So this patient was absolutely clear indication of a post-TAVR medication. Our Enable TAVR trial. And could you show us last slide? And yesterday I briefly showing. This is a multi-center trial is actively ongoing in South Korea. More than 40 centers involved this trial. After successful TAVR procedure, and such like the TAVR, the heart PEP preserved ejection fraction, post-TAVR management using SGLT2 inhibitor quite be the beneficial is that there was our hypothesis, and this year ACC trial, low ejection fraction, half-rep TAVR patients, TAVR trial shows that 30% reduction of a primary endpoint. Even that trial was an open label trial. Our trial is double-blinded trial. So, and we have some discussion time is that technically and combining calcium score was 800. And as you see the aortogram, and there was some severe MAC. Also, septum was very sickened and approximately 18, 19. Is the aortic valve is very narrow. The Vmax is approximately 5, and so we have some discussion is severe calcium and hypertrophic septum, and which valve would be suitable for this patient would be some first discussion point.
Any comments about what valve don't work? I mean, this is pretty calcified, but I think, a sapien valve would be relatively straightforward with predilatation. The question is how much oversize or, given the calcium and, 80 years old. Any comment from the panelist? How would you approach this predilatation? I know most of the time we don't have to, but
looks like there's heavy calcification over coronary system. How is the patient with coronary artery disease?
Coronary artery was mild disease. We check it up coronary angiography. Yes, mild disease.
Actually, the septal hypertrophy is severe. Is there any dynamic obstruction?
any outflow tract obstruction because of the,
No,
septum?
no. Yes.
Yes, there's a concern sometimes if you have a pretty thick
Absolutely,
septum.
yeah. Sometimes it's a SAM and combining hypertrophic LVOT dynamic obstruction, and that would be sometimes vulnerable to the shoe-side LVE.
Yeah.
And we experienced 2 or 3 cases after implantation. Is blood pressure is drop down, and there is a much hypertrophic.
Yep.
The motion LVOT obstruction was happen at the time. So we are full drip on hydration.
Yeah.
Sometimes helpful, and it would be some case such like a very severe hypertrophic myocardium is vulnerable to the suicide LV.
Yeah, highly possibility. Yeah, this patient has calcium volume of about 800 at threshold of 850. Do you regard this as severe calcification, and do you have a graded approach for oversizing for?
Yes, yeah, there is a very critical point in the aspect of technical consideration. So, and the 800 and the absolutely predilation is required. Sometimes we do without predilation, but usually it's combining very severe calcium. The valve itself doesn't pass well. Even the Eberhard system, the reason why we do routinely predilation is our threshold more than 500. We would like to do routinely predilation. That was depending on the in-center in the even Rajmak more than 1,000 he do without any predilation. Also, it's 800. There was yesterday we discussed some severe calcium. So not much severe. Sometimes we do 2,000. Is more than 1,500. That would be some. We discuss which valve is suitable, and if you're gonna use the sapien valve, we try to do just slightly oversizing. Is usually and the very low calcium, we try to do more than 10% or 15%. That would be okay, but moderate to severe calcium, we would like to do less than 10% oversizing, sometimes 5%, 6%. Very severe calcium, we do sometimes 0% oversizing. And the second case would be SJ, Jung-Min will show the most severe calcium is double time calcium is 1,500. He will do -degree impression. So such like a very severe calcified region, and when you do a TAVR procedure, which type is the optimal, the sapien valve is Eberhard valve would be is always some debatable point. I think in South Korea we have 3 times Nabito would be. I'm not sure it's such like a very severe calcium is suitable for Nabito. Although Nabito is a radial pulse similar to the Eberhard system, but very aggressive predilation is required. I think we can treat the Eberhard system well and also sapien system well, and the two options quite similar to this patient. The centers much prefer the Eberhard system considering root injury, and some center much prefer for sapien valve considering non-uniform expansion, not well expansion. If we put the Eberhard system, there was some pro and cons about each the specific type of the TAVR.
So DW, on your trial, the ANOVA TAVR,
Yes,
do you
yeah,
require to have coronaries cleared and
No. It's a coronary obstruction. It doesn't matter, and even though and the combining coronary artery disease, and we can treat the stent. So, and the major problem is on the basis of STS registry, even after successful TAVR, approximately 30% experience recurrent heart failure admission on the basis on JAMA article. The reason why, although we do successfully TAVR procedure, myocardium disease and the reverse cardiac maladaptive remodeling still exists. Our targeting after successful TAVR, if you're gonna use SGLT2 inhibitor, that causes much reverse cardiac remodeling as well as improved heart failure related symptom. That was our hypothesis. So, and the PCI done or not, that is not our exclusion criteria.
Do you plan to do the cerebral protection in this patient requiring pre-dilatation?
Yeah, that is good option. And cerebral, sometimes a very severe calcium, we can consider cerebral protection, but we usually explain the patient the risk and benefit cerebral protection is the price is still high, and if patient don't want, cerebral protection, we do just without the CEP.
But in case of not using cerebral protection, I think in this case, the calcification is mainly located at the tip of the leaflet. So I think we can do the TAVR procedure without predilation, and in order to reduce the risk of cerebral embolization.
Okay, yeah. So why don't you go ahead, DW, go.
Okay,
go,
yeah. As shown in the hemodynamics, very severe calcium, and the Vmax more than approximately 5.0. So I'm going to use the Safari wire, and usually routinely. Okay. And then we will do predilation. we decided to, 요거 보면서 빼봐. We decided to put the sapien, the ultra 26. So we do usually pre-dilation 2 step down sizing and the 20. And then after pre-dilation, we put the sapien valve. So, and sometimes very severe hypertrophy, and we are always concerned about the shoe side elbow. That will sometimes happen. Okay, 자, 줌 한번 해보고.
Which balloon diameter
This
do you
is
use for the pre-dilation?
GMAD balloon 20. Okay, size is 20. Okay, 자, 준비됐어? 천천히 해볼게. 자, pacing on. Okay, inflate. Push. Okay, deplete. Okay, pacing off. Okay. As you can see, 이거 보면서 한번 빼보고 한번 사진 보여주자. Okay, 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3. Why? 1, 2, 3, 1, 2, 3. 됐다. 주세요. Could you show us the previous L2gram? Yep. So at the time of the balloon inflation, we are just guessing the calcium chunk direction and how much calcium. And as you can see, there was a calcium chunk in the NCC, LCC side, but the sinus area is sufficient, and the coronary height is very high. That would be not much higher risk of coronary obstruction. Okay. 들어갈게요. 자, why? 자, 1, 2, 3. 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3. Okay, check it out. This is a sapien 26.
Alan, how much oversizing do you apply in case of Sapien 3?
Generally, if all comers, obviously from nominal to about 10% or so, but the issue is this: sometimes you put in more cc's, but the valve would not take it anymore. Meaning that you can maybe, super strength to push it in. So we generally have a feeling too that you go to a certain level, and if the valve won't take, the balloon won't expand too much more, we'll take it that volume too. So I think there's the plus cc give you option when you're inflating it, but you don't have to put it all in too. So I just generally had a little bit of a feel when you inflate as well.
So if a patient doesn't have much calcium, then how much oversizing do you apply?
About 10%.
10%?
Yeah. If you look at some of the new one, for example, when we're experimenting with the X4, then it's essentially almost zero, the way that they can tune the size. So
these days the palpebral leak incidence is very low, so about 5% oversizing does not make any significant palpebral leak. So
yeah, mainly it's injury that you cannot predict. So I think this distribution of calcium, bicuspid versus tricuspid, I think all become very important.
Okay. Elbow. Okay. I think the position is good. Okay, test. Okay.
Perfect.
자, 조금만 더. 자, 한 번만 더 테스트. 오케이, 준비됐지?
오케이.
자, 천천히 가볼게. 자, pacing on, contrast. 오케이, inflate 쭉. 1, 2, 3, 4, 5. deflate. 자, wait. 자, pacing off. 오케이. Okay, so I'll pull back. Okay, we're gonna check it up. The pressure. Okay. Just wait the pressure. Patient 백업하고 60, 60. Yes. 혈압 조금만 올려주세요.
Look.
줌하고 한번 찍고 와이어 바꾸자. 오케이. 찍어볼게요. 자, 핸즈 좀 빼고. 자, 핸즈 레디. 오케이. So, and we will change remove the system and then put the.
I think
Any
when the
tab
wire
or-
transfers the valve from one side to the other, you always worry about pinning the leaflet down. So get the wire out.
Wire related, right? Central.
Go this way. So
1, 2, 3, 1, 2, 3.
I generally don't even look at it with
Alright,
the wire still. Pigtails much.
Yes. Okay. 더 넣어봐. 1, 2, 3.
All right, the device size wise is 26 to cc overfill, right? Is that right?
Yeah, right. 20,
All right, so
26 to
what about
6
the area?
there was
you
a
know?
7% oversizing.
Seven-
Yeah.
7%
Considering
oversizing,
calcium,
right. Great.
I think oversizing is sufficient. 이제 체크 에코.
All right, that-
에코 좀 얼른 가서 가봐.
This is overfill made very
Yeah.
more
X
shortening
insertion
of
pigtail.
LV part.
오케이. 잠깐만. 자, 프레셔 재고 에코 보고 한번 해보시죠.
I mean, the amount of oversizing depends on who is inflating the device a bit as well, right? So it's really at the end of the day when you go to nominal or plus 2 cc, depends on how hard you squeeze.
깨끗하게
So
프레쉬
it may
좀
not
해봐.
sometimes be possible. So I think that's it's a combination. If the valve is not that calcified, you easily can get to plus 2 cc.
Okay, Kyung-won, can you explain the echo finding? Is that there was some acute complication or effusion or any, yes.
There is no pericardial effusion and no
That's good.
AR.
Tubule.
Could you show us the apical chamber view? Sometimes we experience some 2 or 3 cases combining very severe septal hypertrophy, and after insertion of a TAVR, the valve, we noted a very super dynamic LVOT obstruction. Yes, so at the time we don't know what is the blood pressure dropping, and we try to increase some norepinephrine and just everything, but this does not resolve. And at the time we are full hydration, and then stop the norepinephrine and wait the patient, and the vital sign was stabilized. There was some typical type of suicide LV. Okay, I think there is no acceleration LVOT part, and it seems like there was no significant AR. And okay, we're gonna show the invasive hemodynamics. Okay, 요거 조금 뺄게.
Very good.
Okay.
Dr. Park?
Okay, we're gonna show the hemodynamics, and there is no pressure gradient at all, and there is some AR index more than 30. That's by hemodynamics, and that would be acceptable. So we will check it up the angio.
DW, you said this patient developed atrial fibrillation recently, or just around this
Yeah,
time?
so
or-
and initially presented at the normal sinus rhythm. Today, during the preparation, APIP was developed. Yeah, there was some patient having the paroxysmal APIP or okay.
Right.
이거 빼볼게. Initial admission, normal sinus rhythm. Today, during the preparation, APIP was developed. Okay, test. Okay, 준비됐지? Okay, we will check it out. In the looking at the frame, and the valve frame is expanded well. Okay, 잠깐만. 자, push-up. Okay, good.
Tiny little bit.
Yes, I think there is no little trivial AR, nearly the 0% AR. The valve positioning is good, and like 82%. Okay, pass the view. Okay, enjoy. Good. Nearly 0% AR. Could you show previous
AR.
one?
That's fine.
So, and this is a final, the aortogram and the coronary height in the left and right in the space is sufficient. Although Neoscott line slightly covers coronary risk planes, the overall the space is sufficient. The coronary obstruction risk, it doesn't matter. And the valve, the sapien valve frame is well expanded, and also position is good in the 82.2, and there is no AR, and this is, I think, a successful PCI procedure using the sapien valve, even and the combined severe calcium and the LVH obstruction. And after such like successful TAVR procedure, this patient would be included our ENAV TAVR trial. We will, the double-blind trial is the medication drug for 1 year.
Yeah.
Okay, any comment for technical or clinical part?
How are you going to deal with the atrial fibrillation? Because that could potentially send her back to come back into the hospital and heart failure.
There are, over the last 5 years, there are many clinical trials, and even during the procedure, APIP, there was absolutely APIP, and on the basis of our Asan data and published the American Journal of Cardiology a couple of years ago. And the new onset APIP during or post TAVR procedure could be associated with increased risk of some ischemic event. So absolutely, this patient we will prescribe NOAC, edoxaban or epixaban, and without any aspirin or Plavix. That was a contemporary guideline. And the inpatient without APIP, we just prescribed the single antiplatelet therapy, mainly the aspirin alone, but the patient combining APIP, we prescribe the NOAC alone, and this patient should be for NOAC, and we are mainly use the edoxaban based on our TAVR trial.
Before I finish the case, I would check the level of depth at the left side at the LAO angle after elimination of the device parallax to check the depth at the LCC side.
Absolutely. We're gonna check it. 요거 한번 패럴렉스 없애봐. 측면 한번 잡아봐. 패럴렉스 없애서 쫙 펴서. 그렇지. 오케이, 굿.
Over.
오케이, 박수 한번 찍어볼게요. 준비됐지? 자, 풀샷. Good. So I think his valve position is good and the depth is okay. And I would like ask some panel, and in your practice, you would like to do the high implantation, even the sapien valve?
I tend to implant it high if possible. So, 90-10, or sometimes on one side will be like 0, right? Then this on the left side almost close to 5, 95.5, which is fine. So.
All right. I think it's great cases. In terms of device size-wise, it's very meticulous. You're gonna make a 25, 26 inch, a 2 stage over, a little bit 5%, 7% oversizing, can make a really good, procedural outcome. So, Duk-Woo, from these cases, this is a tricuspid, total amount of calcium is 800, moderate something. And so, two things, why do you select the balloon expandable rather than self-expanding valve? That is the main, you have already mentioned about that one. All right, that's a question.
Yeah, absolutely. I think we can also select envelope valve, and such 500 is not severe, and we can select sapien or envelope valve. If you select envelope valve, I think 29 would be suitable. But sometimes more than 1,000, and we experience at the time some case, our prior experience at the time we put the envelope valve, but the expansion is not well, and even some very inappropriate expansion. So, and after that, and we try to do, even sapien valve is a very meticulously and very cautiously expansion, 0%. Usually okay. So, but on the basis of your experience, you can select the Eberhard system. But in our center, very severe calcified region, we slightly prefer the balloon expandable valve rather than the self-expandable valve.
Thank you. It's a really good, nice cases. Congratulations.
Okay, thank you. Thank you.
All right. Dr. Ahn, can you hear me?
Yeah. Good morning, SJ.
All right, great.
So we also preparing very interesting case today. So first of all, I'd like to introduce my teams, Dr. Bob and Dr. Wee. Dr. Wee introduced our case. Could you please?
Thank you. Good morning, everyone. I'm Seung-Jung, a clinical fellow from Seoul Asan Medical Center. I'd like to briefly present today's case. Our patient is a 68-year-old male who presents with dyspnea exertion classified as NIA class 2. His BMI is 21, and his calculated STS score is 2.5%. He has hypertension and hyperlipidemia. On ECG, he was found to have LVBB, and chest X-ray showed mild bilateral pulmonary congestion. Transthoracic echocardiography revealed a left ventricular ejection fraction of 65%, an aortic valve area of 0.71, and a mean pressure gradient of 70 mm mercury and Vmax of 5.6 mm per sec, which were consistent with severe aortic stenosis. As shown in the parasonal long axis view, mild AR was observed, and in the short axis view, which is pole image, heavily calcified aortic valve was observed. On transesophageal echocardiography, restricted motion of bicuspid aortic valve with flow acceleration was observed. In apical full chamber view, preserved LVEF of 65% was observed, and the Vmax was 5.6 mm per sec with mean pressure gradient of 70 mm mercury was also observed. And on CT imaging, we obtained cross-sectional views at the annulus level, and as well as 2 mm and 4 mm and 6 mm of the annulus. And annulus area measured 441, and the sinus of Valsalva was 798, and the sinotubular junction was 612, and the LVOT area measured 406. The aortic valve calcium volume was 1,147, and coronary height was measured at 12 mm in LCA and 15.7 mm in RCA. The patient peripheral, the arteries were fine without heavy calcification or a severe tortuosity, with a minimum diameter of 6 to 7 mm, which is adequate for transfemoral access. Based on our measurements, a 23 mm adrosapien valve would provide 2.5 area undersize, 7.2% undersize in nominal, while a 26 mm Medtronic evolute valve would provide 8% parameter oversize. And I will hand over to Professor Ahn to discuss our topic plan.
Before, please. So Sapien 3, yeah. So the device's site selection is very tricky in this patient. And in addition, this patient is a relatively young patient, 68-year-old. So frankly speaking, the patient visited another 2 hospitals. So even us, we recommended the our recommendation to have aortic valve surgery, but he refused. But several times we persuaded him to go to the cardiothoracic surgeon, but he refused. So we finally, after discussion with the patient and doctors, so we decided to do the TAVR. So 68-year-old, so the instance of bicuspid among the severe AS population, naturally the instance is more than 50%. The bicuspid aortic valve is 50% underwent surgical or the transcatheter aortic valve replacement. So if we want to do the TAVR in younger patient, we have to know how to deal with the bicuspid aortic valve, particularly the very calcified bicuspid aortic valve disease. This patient aortic valve calcification is more than 1,000, so we consider it a very significant aortic valve calcification. The second point is the patient baseline is RBBB. Could you show us EKG? As you know, the baseline RBBB is associated with very high risk of permanent pacemaker risk. So considering the relatively younger age, we have to avoid the permanent pacemaker implantation. We make every effort to avoid the permanent risk of the permanent pacemaker implantation. The third important issue is the sizing. So regarding the SAPIEN 3 sizing algorithm, the 26 is 17% area oversizing, 23 is 7% undersizing. So actually between. Next. Average effects, I think 29 would be fine. So in this case, we consider the relatively younger age, future coronary access. Regarding the risk of permanent pacemaker, we plan to implant the SAPIEN 3, but the sizing of SAPIEN 3 is not easy, previous one. So could you give me some advice from the moderator and panels?
So, Jung-Min, on the CT, can you tell what type of bicuspid? Meaning, I
Type 1
tell.
bicuspid. Could you
And
show us
which
the
one is
CT?
the fused raphe there?
Yeah.
Is it RL fusion?
Yeah.
RL
No,
fusion.
Right and the non-
yes, RL fusion. Calcification usually mostly located in the NCC and RCC, but fusion is between the RL.
Yeah, so typically when there is sort of this raphe that's fused, and if it is pretty calcified, that obviously has some risk of poking it out of the annulus. So usually that corner we'd like to pre-dilate as well to make sure that the valve can go around that corner, which is the outer border of the arch. So those are the two things, and I would probably be more on the undersizing a little bit, just to make sure it's safe, and you can always post-dilate another CC or something like that, because, you know, annular rupture is no
So
fun.
do you like to
obviously.
select the 23, not 26?
Not 26.
Yeah.
Okay, would
How about
you show the next slide for the evolute series size-wise? We have to choose 29. Is okay?
9, yeah,
All right.
29.
If we gonna
Go
choose
with
the self-expanding, over perimeter oversize almost 20%. We have no other choice. Actually, 29 is relatively big rather than the native sinus diameters, right? So
Also, look at lifetime management, right? So he's young, so he's going to need another valve at some point, and it's easier to do, self-expanding on top of a balloon expandable down the road versus the other way around.
choose, Dr. You choose a 23 1 cc overfill, right?
Yeah, right.
All right.
So,
I want to discuss about this one. Is depending on the calcium amount, right? More than 10,000 heavy calcium, we have to readjust in terms of area oversizing is almost 0%, less than that, right? Even in the reason why maybe area oversizing less than 0%, right?
yeah,
All right, great. And so
5%
that mean important
undersizing.
issues, right? Sizing.
And then there's a raphe as well, meaning that it's the fused is a raphe that is calcified. So that also doesn't matter as much size, but more of any oversize will poke that out as well.
Great.
So if a patient has a low arterial calcification and tricuspid anatomy, so I'd like to choose the 26 and a little bit underfilling, but considering bicuspid anatomy and heavily calcified aortic valve, so I'd like to select the 23 and 1 cc overfill. Make sure
even though this patient has bicuspid aortic stenosis, but the calcium morphology is not that dangerous, I think. So I would target more oversizing, because I'm not sure 23 with undersizing would be good for in the relatively young patient for long-term outcome.
Yeah, I agree with your opinion, but sometimes the good result would be better than perfect result. So
You're right.
Considering the patient is young and like 10 years later, 15 years later, the patient may receive another TAVR procedure. So I'm a little worried about the sizing, 23 millimeter Sapien 3. Next time, what we'll be able to implant?
Next, if we implanted 23 at the Sapien, next valve should be the VALVES system.
So I see
23
some
or 26,
LVOT
23 or
calcification, but the RAFE is heavily calcified. I'm not sure about that. So
LAFE is not heavily calcified. The leaflet is heavily calcified. CT shows the CT calcification.
Not used to looking at it this
Right.
way, but we have like a 4D, like, it's easy to
Right,
see.
chronic,
but-
non-chronic, that's right.
So
don't
let's
like to
see
leave it
what
all
happened
day.
if we implanted the 23, when we implanted the 23. So transfemoral cautious sedation. Just I'd like to cross the valve. Crossing valve is sometimes very difficult in case of the bicuspid anatomy. But you can feel some jet from the
Yeah.
stenosis, and then cross the catheter to the hole, and then I think between here.
Easy to,
Amazing. Do you routinely use standard wire instead of
wire is really good, right?
So I usually use the ring torque wire, a little bit stiffer wire then. So I don't pick the wire to the valve, just it's similar to the coronary engagement. I like to find the hole of our valve and then engage the catheter, not actually engaged, but close to the hole and then insert the wire.
Alan, which wire is commonly used in the United States? In Korea, we routinely use the Safari wire, but it looks like
which wire?
Longitudinal is
Sorry.
also used in the States.
There's two wire basically we use, could be the sort of glide wire, right? Stiff shaft glide wire, straight tip, that's one of them. And the other one is the emerald wire, that is the stiffer one. I think sometimes in different situations, each perform better. If you use the emerald, it tends to have a stiffer tip as well, so it tends not to flop around, so you can actually direct it a bit better. So I think there's two schools of how to cross the valve. There's one just a random turn a catheter and just trying to see whether you can fall into the hole. And sometimes could be very easy, sometimes could be very difficult. The other one is more purposeful, is to understand the structure and where the hole is of the valve and what angle are you in. In a three-cusp view, you basically, be able to line up the right cusp, the non, and the left, and you can have an idea where that hole is. A little bit like Jung-Min is to bring the catheter close to where you think is the opening, and then you do a little bit of, clockwise rotation and point it forward, and then you basically find a hole and a jet. But sometimes, the jet could be very eccentric and push you to somewhere else. And the light wire, meaning the glide wire, could be very difficult because it tends to kind of flop around as well in the jet. And so it's like, try to push a spaghetti through a strong wind, and you will never get through it. So I think the emerald wire is what we use in those situations. What wire do you use in Korea? What brand is that? I'm sorry. What do you use, Jung-Min? What is that wire?
Safari
I
is my
use the-
choice.
No, not this wire, crossing wire.
I use the ring torque wire made by the Cook company. So definitely, I think we need pre-balloon valvuloplasty before implantation. So balloon, please. Coronal height is very high, so there is no issue about the. There is some issue about the device size. What is the balloon size? 18 millimeter balloon. So I like to do some contrast injection during the balloon valvuloplasty.
Dr. Ahn, are you using cerebral protection in this case? This young
No, no,
patient
no.
with heavy calcium.
No. Even though there is no data to support the cerebral protection device used in this case. Ready? Facing on. Inflation. Contrast.
Good. Yeah.
Deflation.
Again. Off.
Off.
Yes, sir.
Facing on.
So after volume valvular plus, the patient vital sign is still stable. Minus, please.
So I think the no data does not mean it is not effective. So in, especially
I
in young
agree.
patients with high risk of cerebral embolization, such a case like bicuspid aortic valve with head calcification, I think we have to tell the patient about the option. And I think if we apply the filter, then we often find a lot of debris.
The
Yes,
difficulty is that obviously, you can make, there's a lot of reason to use it in every case, and there's a lot of reason not to use it in every case as well. But I think the one indication for sure is that if the patient asks for it, we definitely put it in. Because, a lot of patients look around in the internet and they sort of say, I want a cerebral protection. And I think in that situation, pretty much we can grant the wish to the patient to have that done.
So as far as I know, I cannot remember correctly, but as far as I know, the two randomized trial, there are some bicuspid patients, but in a subgroup analysis, even in the bicuspid cohort, the cerebral protection device didn't show any benefit.
Correct, yeah.
So, definitely the cerebral protection device can capture some debris from during the procedure, but definitely we need a further study or further observational, at least observational study to identify the best target for the cerebral protection device.
So this
Implantation
patient
bureau
has RBBB, and also we have to consider future TAVR or something. So how deep do you want to implant? So very shallow or?
So regarding the baseline RBBB, the shallow implantation would be beneficial. But regarding the safety, so I tried the shallow, but not that shallow. In addition, our sizing is a little bit undersized the valve, so selecting the undersized valve would minimize the risk of permanent pacemaker in the future. Ready? Pacing. Contrast. Inflation. Okay. 1, 2, 3, 4, 5. Deflation. Pacing off.
Perfect. Okay, almost done. 23,
Remove.
2 cc on the floor. 1 cc.
One
One
cc,
cc
yeah.
off.
0% area of sizing. Can make,
Around the 5% undersizing.
Jung-Min, did you adjust the height of the valve when you were pacing?
Jung?
I saw you pause a little
during
bit, and
the
then you were,
pacing, yes. That's
before
why
inflation.
yes. Minus.
You can play that back if you have it. And why did you decide to, maybe for the audience? Looks good.
Perfect.
Yes,
The wire is giving you trouble again.
Wire relay. Yeah.
Yeah.
Screw.
Even for bicuspid, his sinuses and everything else is kind of small, not very big for a man.
Minus, please. So minus, please. Yes. We have to make sure the accurate plane for the implantation, but during the autograft, I'm not sure where the device is, so it takes a longer time to start deployment of valve. So I'd like to start markers. You have
Central.
to, yes, usually during the deployment, many operators thought that the calcification line
Just
could be considered as an annular line. But actually in this patient, the calcification line is very above the true annulus line. So that's why I push a little bit more and start to deploy the valve.
I mean, it is.
however, you a little bit push in just before the device inflation.
Yeah,
However,
yeah.
during the inflation, the device is getting pulled
bit.
up,
A little bit, yeah.
right? A little
Yeah.
bit, right?
Yeah, a little bit popped up,
Spontaneously, and
yeah.
so
I think it's
So look
because
at
the conduction was not made one-to-one. So I would take
Jumping a little bit?
Yes. So
push in
Diastolic pressure is above the
and push
50.
out, right?
So
Okay, great.
this is sinus rhythm
Finally,
so far. So could you show us the echo? Diastolic pressure is getting higher and higher to 50, 60. So I definitely think that there is no significant probable leakage. So in case of very calcified aortic valve disease, particularly the bicuspid anatomy, so the undersizing valve, I think the very effective and safe.
Dr. Ahn,
Yes.
Dr. Ahn, recently I have experienced hemorrhagic anemia after sapien 3 valve. After procedure, PVL is mild. However, after 6 months procedure, PVL was increased, moderate PVL, and with hemorrhagic anemia. Do you have experienced hemorrhagic anemia after sapien 3 valve? If you have experienced hemorrhagic anemia, what is your treatment strategy?
Fortunately, I don't have experience of the hemorrhagic anemia after the sapien 3 implantation. So, but I'm not sure that I don't know. I couldn't explain the why the PVL increased 6 months after or 1 year after. But some patients experienced the increased PVL after 1 or 2 years later. So I assume that some device recoiling could happen. The time goes by, but I don't have any evidence. But I assume that. But I don't have any the hemorrhagic anemia after sapien 3 implantation. How about Alan? Do you have any experience?
Mainly in the mitral position, because the pressure difference is much greater. And also, I think I talked about yesterday, is a lot of valve in MAC that has these very calcified crevices that causes higher jet velocity and hemolytic anemia. And fortunately, there's not a whole lot you can do if you can plug them. Sometimes help, but when you plug some of these, it still can have leaks around it and still can have hemolytic anemia. So then it becomes a bit of a supportive situation. Obviously, the free hemoglobin can cause a lot of renal damage as well. So you have pigmented renal failure, which is obviously could be very bad. But if it's mild and doesn't cause renal dysfunction, it'd be supportive, meaning that if they lose blood, you might give them some blood later on. So, and if, let's say it's not big enough to plug. If it is big enough to plug, you might want to do a paravalvular leak plugging later on.
Yeah, that
How
is
about the micro aortic position?
Yeah, they're relatively rare, and
Yeah.
because the pressure difference is not as much.
Concerning the hemorrhagic anemia in Japan is a clinical issue. in ocean registry data clearly revealing approximately 1% of patients experience the hemorrhagic anemia, and it's significantly relating to the mild PVL, even mild. But while the procedure is now, oversizing ratio is keeping to more than 5 to 10%, the rate of the hemorrhagic anemia significantly decreasing. So the oversizing ratio is so important to reduce the risk of hemorrhagic anemia.
Hemodynamically perfect, right?
Ready?
No gradient, diastolic is almost perfect, normal.
Necrotic notch too. Yeah.
There's just much to watch. Ready? So we can see the very minimal PVL. I'm not sure this is the paravalvular or valvular, but the diastolic is very high. So
Perfect.
I like to remove the pigtail.
Yeah.
And then I like check the final autogram. Ready?
Yeah.
No AR.
Okay, no AR and sinus
Great.
rhythm.
Addition.
Sinus rhythm. So I like to remove the pacemaker because I have nightmare, the nightmare of pericardial tamponade due to the temporary pacemaker. So this is our final
Another view, right?
final result. So the take-home message would be that in case of very calcified bicuspid aortic valve, sometimes the less undersizing valve would be very effective and also very safe. So don't do oversizing in case of very calcified aortic valve disease, particularly in bicuspid anatomy.
Great.
Thank you,
great.
SJ, and thank you, Alan.
In bicuspid anatomy concerns, you have considered a little bit, device position was a little bit high position or something like that. Is any difference in terms of tricuspid?
Yeah, so someone suggests that the high position, particularly the high position to cover the whole leaflet in case of bicuspid. But I don't treat the bicuspid so too much differently from the tricuspid anatomy. Just a similar, the implantation depth would be good for even for the bicuspid anatomy, I think.
Still, it's really good cases. You still have 5 minutes, remain. You have to do something more. All right. Anyway, really, thank you for your nice presentation, Dr. Ahn.
Thank you. So why don't we just go on to the feature lectures. So the first speaker is Dr. Yamamoto from Toyohashi Heart Center, and he's going to talk about TAVR strategy for coronary protection, novel simulation technique.
Okay, thank you very much for inviting me. It's a pleasure to be here. And here is my disclosure. So the procedure of TAVR procedure in United States is very safe and established procedure. Approximately more than 1,000 patients can be done safely. But the very interesting paper provided by Japanese young physician, Dr. Ochiai, he learned the procedure of TAVR and worked as a clinical fellow in Cedars-Sinai Medical Center, US. And post-CT scanning simulation revealed the risk of the future TAVR in TAVR. That means the sinus sequestration. He provided the risk of the sinus sequestration. If we choose a self-expandable valve, the risk of sinus sequestration is 45%. In other words, in contrast, if we choose a balloon expandable valve, the risk of the sinus sequestration is 2%. But this is a very large anatomy, particularly large sinus or valsalva, large aortic annulus area. So he came back to Japan and the same study he did in Japanese, particularly small anatomy. So that's interestingly, as we recently tried to high implantation, if we do the high implantation, for example, Eberhard series, if we do the high implantation technique, the risk of the sinus sequestration is baseline is 40, but if we do the high implantation, the risk of the sinus sequestration increasing with 64%. In addition, if we choose the Sapien 3 series, the conventional very low implantation depth is the risk of the sinus sequestration is 5%, but that means it is a relatively higher than Western cohort, in Asian particularly small anatomy cohort. And if we adapt to the high implantation technique, the risk of the sinus sequestration increasing 17%. So what should we do if the patient will face the future TAVR in-TAVR procedure? For this is a very simple sample for our case. Experienced one case of the TAVR in-TAVR procedure. How can we detect the coronary obstruction or sinus sequestration in real time, not a virtual CT scanning images? And this patient is obviously the recurrence of the severe aortic stenosis that provided by the echocardiography showing mean pressure gradient more than 40 and peak velocity is more than 4. And of course, we can do the transfemoral approach. And so how can we evaluate the risk of the coronary sinus sequestration using the CT scanning, VTC, VTA, or VTSJ? And how can we measure? For example, where is the appropriate portion of the measurement? The CT scanning, sometimes halation, blooming effect, some interference between the valve and the coronary oscillator. So how can we evaluate? Very difficult. And Japanese worker is Dr. Fukui, reported in SEOUL intervention the risk of the sinus sequestration using the CT scanning imaging. And we check the neoscat plane and coronary risk plane. And if the bioprocess above the neoscat plane or coronary risk plane, we check the VTA, more than 4, 2 to 4, and less than 2, low, intermediate, high. But if the commissure or coronary alignment is inadequate, the basilica or leaflet cut device technique is insufficient. So that's another issue we face. So anyway, how can we define or predict the risk of coronary obstruction? It's very simple procedure, very simple technique I will show. It's a simultaneous root injection during BAB. This is a pre-dilatation during the TAVR in-TAVR procedure, and completely balloon is dilated and simultaneously injected. So can we see the both coronary artery after the complete balloon dilatation? So we can see the both coronary artery. So I think this patient is a no risk of the coronary obstruction. Okay, so that means a schema clearly revealing that is a scenario of this patient. So I don't do the coronary protection for this patient, but this patient is evaluated as intermediate risk for the coronary sequestration risk, the pre-procedure CT scanning, but no. And still, we can see the left coronary artery, but RCA didn't show, okay? But it is a kind of geometry, it's very usual. So RCA, we have a limitation, but LCA is very helpful to identify the risk of the coronary obstruction. For example, like this, we can see the left coronary artery. Okay, so no evidence of the coronary obstruction during the TAVR in-TAVR procedure. And surprisingly, first TAVR using Sapien 3, mean pressure gradient 14, but Sapien 3 ultra residual valve, after the TAVR in-TAVR procedure, mean pressure gradient 8. So that is a very good advantage of the residual tissue, very low compliance. That meaning to the relating to the very low mean pressure gradient after TAVR in-TAVR procedure. So we have beta hemodynamics using the Sapien 3 ultra residual valve. So this case is summarized in European Heart Journal case report. That means during the valve deployment, sometimes the RCA interference causes the no flow of the RCA, but it's usual story. But we can see the LCA flow like this, we can check it, and we can predict the coronary obstruction during TAVR in-TAVR procedure simultaneously, okay? But this is a risk. This causes obtains the risk, the stroke and acute AR. I have acute AR in TAVR procedure. So that's the most important thing is to predict in real patient, in undergoing the patient, patients undergoing TAVI. So that means applying this method during initial TAVI may enable the risk of coronary obstruction in the future TAVR procedure. I do now. So that means this is a conventional SAPIEN 3 ultra residual valve implantation. I inflated the S3UR completely, and then at this portion, I injected again. And we can see the left coronary flow of this. So that means this patient has no risk of the coronary obstruction, especially in the LCA. You know what I mean? Yeah, like this. Okay, so that's a 100% safety of the TAVR procedure for this patient. And we check also the post-procedure CT scanning, and post-procedure CT scanning clearly revealing the position of the RCA is beyond the THV. Okay, so that means the 100% of the future TAVR procedure for this patient, no coronary obstruction, no sinus ejection risk, I provide for this patient. I can tell that this patient has no risk of the coronary obstruction. So in summary, this is a take-home message. So simultaneous root injection during THV deployment allow for real-time assessment of coronary blood flow. And in addition to the conventional CT analysis, this technique may serve as an effective method to predict the risk of coronary obstruction in future TAVR procedures. Thank you for your kind attention.
Great. Maybe any question for Dr. Yamamoto at this point? We can come back to. So maybe just comment on the right coronary again, meaning that if it's above the valve, you may still obstruct it because of the balloon, because you couldn't tell the right side. So maybe clarify that. I'm not quite sure that.
Exactly. Sometimes the right coronary artery flow can be seen, but in some cases we can't identify the RCA flow. But after the CT scanning, the risk of the RCA obstruction is low. That means a combination to predict the future TAVR procedure safety. It's very important. During the procedure, simultaneous injection, and post-CT.
Would you please explain why we don't see RC flow? I don't understand the mechanism.
It's a kind of the geometry. The device is attaching to the right side, right coronary side. That means the flow didn't allow to go inside the RCA. It's very difficult to.
Because the balloon is deviated to the right side?
Yes, right side. Generally.
Great.
Thank you.
Great.
I noticed the pigtail catheter in the aorta was actively moving. Who manipulates it? The second assistant?
Yes, second. Sometimes it's a combination is so important. And sometimes the second operator timing is also important. Full impression, 1, 2, 3, and injection is the appropriate manner.
Yeah. Okay, thank you so much, Dr. Yamamoto. So the final lecture for this session is going to be given by Dr. Eberhard Grube, and he's going to talk about future of structural heart interventions. Eberhard.
Thank you very much, Alan and SJ. Topic of my presentation, present and future of structural heart interventions. These are my disclosures. And this is a roadmap of my presentation, basically covering all three valves. And I hope I can do this in the 12 minutes. So I would like to start with some foundational reflections. Structural heart disease. The first use of the term structural heart disease is referring to a new category of transcatheter therapies. Structural heart disease is a basket meant to include all non-vascular procedures utilizing catheter-based technologies. Structural heart disease emphasizes the confluence of two fully evolved concepts, non-vascular image-guided therapy and multidisciplinary heart team strategies. Structural heart disease requires significant adjustments in training of interventional operators and imagers and modified treatment milieus and clinical care pathways. So trends and future direction in structural heart disease with a focus on the new areas of transcatheter valve interventions. We know transcatheter valve therapies are at very different developmental stages: TAVR, mitral, and tricuspid. Moving to the TAVR revolution, it is an established leadership, as we all know. However, I would like a few glimpse backs at the beginning of this journey, which is today basically common practice. That was not always the case. Zuckerberg at the Harvard commencement said, "It's good to be idealistic, but be prepared to be misunderstood. Anyone working on a greater vision will get called crazy even if you end up right." So true, particularly looking at this team who basically invented TAVR. And you can see here the very first transcatheter aortic valve implantation in April 2002. Look, the first implant. None of these three knew what the valve would do. Would it fly away or would it stay? Even the master wasn't sure. I will never forget these images. They are ingrained in my brain. And of course, the early skeptics came up. This crazy and senseless project will fail and represents unacceptable and unethical experiments in humans. Just digest these words. People at the time when I started it wanted me to be in prison, actually. So today, TAVR is becoming mainstream therapy, saving lives and improving non-surgical quality of life. TAVR gave birth to structural heart interventions. Basically, we know TAVR is based on three pillars: heart team, image-guided therapy, and life journey. Aortic stenosis is a lifelong journey with upstream and downstream aspects. If we look at the upstream aspects, improved diagnosis with AI and machine learning and biomarkers, and you can see here artificial intelligence and machine learning will play an important role in future screening of valvular heart disease. 12 million electrocardiograms, 1.5 million echocardiograms, 8 hospitals led to the Cactus trial, which is the first of its kind of an AI safety net rolling out in 6 emergency departments, started in the second quarter of 2024. The downstream aspects, mainly durability and therapy sequencing, obviously. We know that lifetime management and durability is multifactorial with patient-related, prosthesis-related, and procedure-related factors. An ideal THV should replicate a healthy aortic valve going through 40 million cycles per year with unfaltering function. That is what we would like to see. We try to ensure durability by improving deployment accuracy and ease of use, long-term trial follow-up, and bench testing. All valves, bioprosthetic valves, surgical and catheter-based valves, will at some point fail, and we will face valve-in-valve procedures with an increasing number. It is all about leaflets and material science innovation. Moving on to mitral valve therapies, which I believe is works in progress. We know mitral valve, complex anatomy, and it's a complex disease with many overlapping solutions. We have 2 entities, primary and secondary MR, with very different treatment paradigm between those 2. Annual incidence of primary 30%, on secondary 70%. Surgery penetration in primary high, secondary low, and guidelines class 1 in primary and class 2A in secondary. The TEER indication for those 2, obviously only in primary, only inoperable patients, and in secondary MR, only high-risk patients. The transcatheter edge-to-edge therapy obviously was an important step into treating mitral regurgitation. TEER has transformed the treatment of mitral regurgitation over the past decade, both for primary and secondary MR. With additional evidence, experience, and indications, the clinical use of TEER has steadily grown. Guidelines have evolved to support appropriate use of TEER for both PMR and SMR. However, the landmark study COAPT shows, after 5 years, 74% death or heart failure hospitalizations and 57% for all-cause mortality. Clearly, TEER is effective in many, but not all patients. But unfortunately, it also permanently deforms the mitral valve, precluding many future transcatheter options. Also, looking at treatment efficacy and stability at 2 years, you can see surgery is clearly superior to TEER. The portfolio of transcatheter mitral repair replacement is summarized here. We don't have to repeat that. On the repair side, we do poorly. On the replacement side, this is where the focus right now is. Here you can see direct, indirect TMV annuloplasty devices. Most of them has disappeared. Carillon is on the market, and the Dragon Ring, Ament, and Valfix are in early clinical trials. Looking at transcatheter replacement, we do know that we have anatomical limitations with first-generation TMVR devices, high screen failure rates with LVOT obstruction, large annuli, and MAC. Second-generation devices address those by basically have an open frame design, supraannular designs, low profile, low presence in the left ventricle, and LVOT sparing and height adjustments. So if we look at clinical trials, TAVR and mitral studies, 2 trains, 2 speeds, multiple anatomic targets responding differently to transcatheter therapies, unstable control therapies, GDMT and evolving TEER, complexity of transcatheter mitral valve therapies, frequent screen failures, marked delays in enrollment times, and challenging and fragmented clinical trial pathways. However, I would still make a case for the development of catheter-based therapies despite the setbacks. Progression towards minimally invasive interventions impact clinical outcomes, quality of life, and healthcare cost. Moving to tricuspid therapy, promising newcomers. We know tricuspid regurgitation is not an innocent bystander. It's not a forgotten valve, but it is probably a forgiving valve. We know the evolving landscape of therapies. We've seen yesterday beautiful presentations. Which therapy at what time is still open in principle? What is the best intervention for which disease entity? How do we choose the best treatment for tricuspid interventions? Again, tricuspid valve transcatheter clinical trials, additional challenges. Some important on the left side, multiple registries and EFS, as we all know, and new randomized trials, Triluminate, TRISCEND-2, and CLASP-2. Some important safety issues, right ventricular failure, bleeding, and new pacemaker with TTVR, amplified procedural imaging required extended training, management of SEOULs requiring active EP engagement, optimal endpoint confusion, must account for pro-placebo effects, and breakthrough device pathways in the US has rushed device approvals, probably with lacking evidence. The FDA approved 2 transcatheter tricuspid valve therapies, the EVOC and the CLIP. Transcatheter, if we compare those two, TEER versus TTVR, both TriClip and EVOC, importantly reducing severe TR, where replacement is superior to TEER. Safety profiles favor TEER versus over replacement, although both therapies met performance goal safety endpoints. Neither therapy had significant impact on reducing mortality or heart failure hospitalizations during early follow-up, 6 months and 1 year, but later follow-up indicates a trend favoring improved clinical outcomes with replacement. So I would like to finish then with final thoughts and key lessons. Basically, high screen failure rates in mitral and tricuspid patients are most often due to technology and anatomy mismatches. Clinical trials have been impacted by slow enrollment, underpowered and imprecise endpoint assumptions, and overly aggressive use of composite endpoints and PROs. Expect and hopefully embrace dynamic changes in diagnostic, AI, and machine learning technology and ecosystem imponderables. So in today's fast-changing, turbulent world, it is hard to predict the next year, not to speak about the next 10 years. However, the future of medicine, and specifically of structural heart, is not something to predict. It is something to build. With the last evolution of structural heart disease, we can look back with pride and astonishment and implement the experience we built to the existing unmet needs, driving innovative therapeutic options forward. With that, I would like to thank you again and have a great day.
Thank you, Eberhard. Maybe stay there for a few minutes. Just any questions from the panelists? As you know, when industry develop technology, they want to have as big a market as possible, right? Because otherwise it's very expensive. And in the mitral space, obviously beyond TEER, do you think there's a really great unmet need to replace the valve? Or is it only a small group of people, for example, with patients that are with MAC, right? So very difficult for surgery, very difficult for anything else. What is your sort of looking ahead? Should we just solve everybody for a mitral valve replacement, or is it really a selected group?
Well, we talked about that yesterday already a little bit. And I mean, all the trials do have a MAC registry. I think overall we can be in the replacement scenario. MAC actually, patients with MAC actually work quite well, both Intrepid and EVOQUE, when EVOQUE was used in the mitral space. I think this is something that needs to be studied further. Overall, I think we are going, until now anyway, into the wrong direction, because if you recall, and this is the topic of my talk later on, and that's why I spared this here in this talk, I think we have to, if we trail the surgeons, then probably we will not be very successful, as you know, both for replacement and for annuloplasty. Annuloplasty, we don't have much, and even in the replacement scenario, we are up to the ones that are prohibitive for surgery and for TEER. So it's a very small group of patients, and that's why the enrollment is so slow and the numbers are so low. However, dollars will be spent in valves because first generation, as we all know, is not so good. My prediction is, well, that we move forward, but we have to get other solutions in order to address this, particularly intermediate and lower risk patients. And I will talk about this afternoon.
Okay, thank you.
I'm a guy of DS era, but I was told that there are so many different devices, different mechanisms to reduce restenosis. But nowadays, after DS is introduced, then every other device is gone. I think that's what exactly we are seeing in the going on in the mitral and tricuspid field, because there are so many devices with so many different mechanisms. So, in your perspective, which device will prevail eventually? Valve replacement or tri-clip? Or do you think we still need so many different devices?
Yeah, I humbly disagree with comparison of mitral and tricuspid. I think those are two different animals. I think the mitral valve is different from the tricuspid valve in many ways. And I believe that on the mitral space, there's not much that we can say as far as, it's only TEER basically. And now we have more experience with TEER and we see more patients are coming back. We know that. And I always said that TEER is a very, very safe procedure. And that is a blessing and a curse. The blessing is that we really can treat mitral regurgitation. The curse is that the final result, actually not many are paying attention to the final result. We do have to eliminate mitral regurgitation. It's not good to just lower 2 grades of mitral MR. That's not going to do a long-term job. On the tricuspid side, I think we're still learning. Number one, it is a more forgiving valve because the right ventricle is also more forgiving. TEER, clearly, as I tried to point out, TEER and T-TEER and replacement is not impacting any treatment that we do on the right side is not impacting mortality. At the end of the day, we know patients are feeling better. Is that our goal? For me, no. It is good to treat patients so they can feel better, but our ultimate goal should be impacting mortality. That's why we have these endpoint struggles and these adaptation and adoption to these confounding endpoints. I think we have to be a little bit more rigid when it comes to treatment options and what the endpoints are in order to really say this is the treatment of choice.
Yep. Thank you. Yeah. Thank you very much, Eberhard.
Yes, I have a simple question to Dr. Yamamoto. Anyway, I've seen yesterday the case of a unicorn, case. And so what do you think is kind of a transcaster lipid modification unicorn and basilica? Do you believe that first? And
yeah, actually, unicorn technique is so impressive for me because, for example, the simultaneous root injection. For example, we see the risk only in LCA, so unicorn do the LCA leaflet, okay? And if the risk is only focused on the RCA, so unicorn do the RCC. So that the unicorn is very simple because the basilica technique sometimes takes a time, and we need two modifications if the coronary artery has both risk, but unicorn is so simple. So that's I think the unicorn technique is so impressive. If the risk of the coronary artery sinus sequestration only focus on the, for example, RCA or LCA only. But what is your consideration for the?
Any procedures, even in the sentinel, cerebral protection, is spent a lot of money. Those, and however, we didn't find any, efficacy concern. And so, what I want to talk is even in the, procedures, any procedures, we have to prove in terms of, efficacy concern for us, and is it really better than, the others? As we have to do that personalized thing, right?
Yeah, but the leaflet cut device is so expensive, so that I think unicorn is more cheap.
Great, thank you very much. So we'll end the session and ask the next session's moderator to come up.
Good.